Welcome to the Deep Dive. Today we're jumping into a really common issue that affects, well, just so many dogs. Cranial Cruciate Ligament Disease, or CRCL.
Yeah, you often hear it called a torn ACL in people. Similar idea. It's less frequent in cats, but honestly, it's a massive reason for dogs having trouble with their back legs.
Exactly. So think of this as our focused look at this condition. It can seem complicated, right?
It can.
But whether you're listening because you own a dog, or maybe you're just interested in animal health, or even just how bodies work, this deep dive should give you some valuable insights. We'll cover what it is, why it happens.
Who gets it, how vets figure it out, and importantly, the treatments available, all that good stuff.
All right, let's get started then. So in simple terms, what is CRCL disease? What are we actually talking about?
Okay, so at its core, CRCL disease is when that specific ligament, the cranial cruciate ligament, inside the knee joint, the stifle, starts to fail.
Starts to fail, meaning it breaks down.
Yeah, it can be a sudden break, like an acute tear, or sometimes it's more of a gradual process, a degeneration over time. Either way, it leads to the knee joint becoming unstable.
Unstable, like wobbly.
Pretty much. The joint isn't held together as tightly as it should be, causing looseness, pain, and eventually arthritis.
Okay. And what's the ligament supposed to be doing in a healthy knee? What's its main job?
Right, so the CRCL is a really key stabilizer. Think of it like a strong internal rope. Its main functions are to stop the tibia, that's the shin bone, from sliding forward relative to the femur, the thigh bone.
Yeah.
It also limits how much the tibia can twist inwards.
Okay.
And it prevents the knee from over-straightening or hyperextending. It's actually got two parts, interestingly.
Two parts.
Yeah, a craniomedial band and a caudolateral band. The craniomedial one is tight whether the knee is bent or straight. It's kind of the main stabilizer. The other one, the caudolateral, is tight mainly when the leg's straight.
Got it. So if that ligament is damaged or gone, what happens? What tries to take over?
Well, the muscles around the joint have to work much harder to try and keep things stable, to stop that tibia slipping.
Compensation.
Exactly. And there's this protective reflex, actually. When the dog puts weight down, the hamstring muscles at the back of the thigh contract automatically.
Oh, interesting.
Yeah, and that helps pull the tibia back slightly, reducing some of the strain on the damaged CRCL. But it's not a perfect fix, especially long-term. The muscles can't fully replace the ligament's job.
Right. So how does the ligament actually get damaged? Is it always like a sudden sports injury, a big dramatic tear?
Not always. That definitely happens, but there are a few ways. In very young, growing animals, sometimes a sudden, heavy load can cause an avulsion.
Avulsion, meaning?
It means the ligament tears away right where it attaches to the bone, sometimes taking a tiny chip of bone with it.
Yeah.
More common on the tibia side.
Okay. And then the classic sudden tear.
Right, the acute rupture. That's often from trauma, maybe landing awkwardly from a jump, a sharp twist, especially with the foot planted or the knee bending backwards too far.
Hyperextension, yeah.
Exactly. This usually causes a tear right in the middle part of the ligament, and often there wasn't necessarily any underlying weakness beforehand. It's just pop.
And you mentioned this is common in cats.
Yes, actually. For cats, this kind of acute traumatic rupture seems to be the most common reason they develop CRCL problems.
Okay, so that's the sudden stuff. But you also mentioned a more gradual breakdown. That sounds different.
It is, and it's actually more common in dogs, especially middle-aged to older ones. We call it progressive chronic degeneration.
Degeneration. So it weakens over time.
Precisely. The exact why is still debated. But we see changes in the ligament itself. It happens more often in dogs over 5 years old, and especially in heavier dogs, say over 15 kilos or about 33 pounds.
What kind of changes?
Well, the ligament loses its elasticity, its stretchiness. The collagen fibers, which give it strength, become disorganized, weakened. Sometimes the tissue even starts to change and look more like cartilage. That's called chondroid metaplasia. Not good for a ligament.
No, definitely not. What things contribute to that gradual weakening?
It seems to be multifactorial, lots of potential players. Repetitive minor stresses, maybe from slight coordination issues between nerves and muscles, just the normal aging process. Then there are physical factors, conformation.
Like how the dog is built.
Exactly.
Yeah.
Things like having a very steep slope at the top of the tibial plateau angle, or TPA. Or if the kneecap tends to slip out of place, that's medial patellar luxation.
Right.
Even the shape of the groove in the femur where the ligaments sit a narrow intercondylar notch can be a factor. Breed predisposition is huge, too.
Which breeds? We'll get to that more later, I
Oh,
guess.
we will, yeah. Also, poor muscle tone, maybe from inactivity or previous injury. And there's even some thought that immune system factors might play a role in the inflammation and degeneration.
Wow. Okay. So it's not necessarily one big event. It could be lots of tiny injuries adding up.
That's a great way to put it. We talk about microruptures, tiny microscopic tears within the ligament fibers.
So they don't cause lameness right away.
Maybe not obvious lameness, or maybe just very slight intermittent stiffness that goes unnoticed. But these microruptures accumulate, weakening the whole ligament over time.
Until.
Until eventually, even just a normal activity like jumping off the sofa or turning quickly can cause the final complete rupture. Or it might just progress to a significant partial tear that causes more obvious problems.
And these tears can be partial or complete, you said.
Yes, a partial tear means only some fibers are torn, so there might be some instability, but the ligament is still partially intact. A complete tear means it's fully ruptured, leading to much more instability.
Okay. And if that instability isn't treated, what happens inside the knee? What are the consequences?
Well, the stifle joint really doesn't like being unstable. It leads pretty quickly to degenerative joint disease, DJD essentially, arthritis.
How quickly?
We can see arthritic changes starting within just a few weeks of the injury. It can become quite significant within months if left unstable.
Wow. That's fast.
It is. And another major issue is damage to the meniscus. That's the C-shaped cartilage cushion inside the knee.
The shock absorber.
Exactly. Especially the inner one, the medial meniscus. Its back part, the caudal horn, often gets torn or crushed because of the abnormal sliding motion in the unstable knee.
How often does that happen?
Estimates vary, but studies suggest anywhere from, say, 33% up to maybe 77% of dogs with CRCL tears also have medial meniscal damage. It's very common and adds significantly to the pain.
Okay, that makes sense. So let's talk about who gets this. We mentioned it's common, the most common cause of hind limb lameness, right?
Absolutely. It's a huge reason for dogs being lame in their back legs and a major cause of knee arthritis.
Are certain breeds really more prone to it? You mentioned large breeds.
Definitely. Large and giant breeds like Rottweilers, Labrador Retrievers, Newfoundlands, Mastiffs, they have a higher incidence. And interestingly, they often develop it younger, sometimes under 4 years old.
Younger than the typical degenerative cases.
Yeah, suggesting maybe a stronger genetic or conformational component in those breeds. But it's not only big dogs. West Highland White Terriers, for example, are a smaller breed that seems overrepresented.
Huh, interesting. What about age generally?
Overall, the risk definitely goes up as dogs get older, particularly over 5. But like we said, those big breeds might show up much earlier, even around 2 years old sometimes.
And sex. Any difference between males and females?
There seems to be a trend. Studies suggest that neutered females might be more commonly affected than other groups. The reasons why aren't totally clear, maybe hormonal influences or differences in conformation post-neutering.
Okay, so if you're an owner, what signs should you be looking out for? How would you know if your dog might have a CRCL problem?
The main sign is usually lameness, of course, but how severe it is can vary a lot.
Depends on.
Depends on whether it's a partial or complete tear, if it just happens suddenly or has been brewing for a while, whether that meniscus is torn too, and how much inflammation and arthritis is already there.
Right, and it can happen in both legs.
Oh, absolutely. Bilateral disease is quite common, though they might not rupture at the exact same time.
So what specific things might an owner notice besides just limping?
Well, if it's a sudden acute injury, they might recall a specific event, yelping during play, slipping, landing wrong, followed by immediate, often severe lameness, maybe holding the leg up completely.
Okay.
But with the more common degenerative type, it might be more subtle initially. Maybe just slight stiffness after rest or lameness after heavy exercise that seems to improve a bit with rest.
That intermittent lameness you mentioned.
Exactly. That pattern of lameness coming and going over weeks or months is really suggestive of a progressive partial tear that's getting worse.
Oh.
Eventually, it often becomes more consistent and severe. They might also sit abnormally, sort of sticking the affected leg out to the side.
And when a vet examines the dog, what are they looking for?
They'll assess the lameness, obviously. They'll feel the knee carefully for swelling, which we call joint effusion or fluid buildup. They'll check for pain when flexing or extending the joint and listen or feel for a grinding sensation that's crepitus. Often the dog will stand holding the leg slightly bent, reluctant to fully straighten it.
And those specific tests, the drawer test.
Right, those are key. The cranial drawer test involves stabilizing the femur and trying to gently slide the tibia forward. If the CRCL is torn, you'll feel abnormal forward movement, like opening a drawer.
Well, yeah.
And the tibial compression test works a bit differently. You flex the ankle joint while holding the knee steady. This tenses the muscles, and if the CRCL is ruptured, it causes the front of the tibia, the tibial crest, to pop forward.
Both checking for that instability.
Exactly. Vets might also feel a thickening on the inside edge of the knee, especially in chronic cases. We call that a medial buttress. It's fibrous tissue buildup as the body tries to stabilize the joint.
And you mentioned hearing a click.
Yeah, sometimes during manipulation you might feel or even hear a distinct click or pop. That's highly suggestive of a torn meniscus caught in the joint.
And then muscle loss.
Yes, over time, because the dog isn't using the leg normally, the thigh muscles, especially the quadriceps on the front, will start to shrink or atrophy. You can often see or feel a difference compared to the other leg.
But these tests aren't always positive.
Correct. Especially with partial piers, the instability might be subtle, or if the dog is very tense and guarding the leg, or if there's a lot of chronic scar tissue already formed, it can be harder to feel that drawer sign or tibial thrust clearly without sedation sometimes.
Okay, so let's just quickly recap the main causes and risk factors we've touched on.
Sure. So, causes boil down to acute trauma, those repetitive micro-injuries leading to degeneration, maybe excessive loading on the stifle, and that underlying progressive weakening process.
And the big risk factors.
Obesity is a huge one. Extra weight equals extra strain, patellar luxation, the kneecap slipping, and those conformational things. The steep tibial plateau angle, the narrow groove in the femur, and of course, breed predisposition.
Right, so the vet suspects CRCL. How do they confirm it and rule out other things?
Good question. Diagnosis involves putting together the history, the exam findings, and usually imaging. But first, you think about differential diagnoses.
Other things that could look similar.
Exactly. Like in young puppies, sometimes they just have general joint looseness that improves as they mature. Or patellar luxation causing lameness on its own.
Okay.
Could also be injury to other ligaments, like the collaterals on the sides, problems with tendons, like the long digital extensor, cartilage issues like OCD, osteochondritis, dissecans.
More serious things, too.
Yeah, unfortunately. Things like bone cancer, other tumors or fractures, maybe an avulsion fracture we missed on exam, and much less commonly, a tear of the other cruciate ligament, the caudal one.
So imaging is pretty important then, x-rays.
Absolutely essential. While x-rays usually don't show the soft tissue ligament directly,
Right, they show bone.
they show bone and they show signs of the problem. We look for evidence of joint effusion. The joint capsule looks swollen. We look for arthritis, those bony spurs called osteophytes and enthesiophytes around the joint. We might see that the femur is sitting slightly forward relative to the tibia. In avulsion cases, you might see the bone fragment. And x-rays are crucial for ruling out those other bone problems, like fractures or tumors.
And for planning surgery.
Definitely. For the osteotomy procedures especially, specific x-ray views and measurements are needed to plan the cuts. Sometimes, particularly in cats, you might even see calcification within the ligament or menisci on an x-ray.
What about other imaging, like ultrasound or MRI?
They can be used. Ultrasound can sometimes visualize the ligament and meniscus, but it's very operator dependent. MRI gives excellent detail of soft tissues, but it's expensive, requires general anesthesia, and isn't as widely available or typically necessary just for diagnosing a standard CRCL tear. Usually the exam and x-rays are enough.
Okay. Any other diagnostic procedures? You mentioned joint fluid.
Yeah, arthrocentesis, taking a small fluid sample from the joint with a needle.
What does that tell you?
Analyzing the synovial fluid can confirm inflammation is present, help characterize it, and importantly, help rule out other causes of joint swelling, like joint infections or immune-mediated arthritis.
And the gold standard.
Arthroscopy is often considered the gold standard. It's minimally invasive surgery using a tiny camera inserted into the joint.
So the surgeon can see directly inside.
Exactly. They get a magnified view of the cruciate ligaments, the menisci, the cartilage surfaces. It allows for the most accurate assessment of exactly what's torn, especially partial CRCL tears and meniscal damage. And often, they can treat the meniscal tear right then and there through the same small incisions.
Makes sense. And if you looked at the damaged tissue itself, say under a microscope,
Right.
what would you see?
Pathologically, you'd see signs of inflammation in the joint lining, synovitis, damage to the articular cartilage, maybe fraying or erosion, those bony osteophytes. meniscal tears, of course.
And the ligament itself.
The ruptured ligament fibers would look abnormal, maybe glassy or hyalinized, with disorganized collagen, scar tissue formation, maybe even areas of cell death, necrosis, just not the nice, parallel, strong fibers you'd expect.
Okay, diagnosis confirmed. What's the path to recovery? What are the treatment options?
Right, the main goal is to stabilize that knee. And generally speaking, surgery is recommended for most dogs
Why surgery over just rest and meds?
because surgery provides stability. This leads to faster recovery, better long-term limb function, and it helps slow down the progression of that inevitable arthritis compared to non-surgical management.
So non-surgical or conservative management isn't usually advised.
It can be an option, maybe for very small dogs or older dogs with significant other health issues, or if finances are a major barrier. It involves strict rest, anti-inflammatory meds like NSAIDs, weight loss, and physical rehab.
Does it work?
Some dogs can become functionally sound, meaning they get around okay for daily life. But the instability remains, the arthritis progresses, and they're unlikely to return to full athletic function. Studies suggest maybe only about 2/3 achieve acceptable function after a year, and arthritis is still a problem. So surgery is usually the better long-term bet for active dogs or dogs over, say, 10, 15 kilograms.
Okay, so surgery it is for most. What happens after the operation? Post-op care sounds critical.
Absolutely crucial. Success isn't just the surgery itself, it's the recovery period. Strict activity restriction is number one.
How strict and for how long?
Very strict initially. Short, slow leash walks, only for bathroom breaks. No running, jumping, stairs, playing. The duration depends on the specific surgery performed and how the dog is healing, but usually we're talking 8-12 weeks or more of restricted activity, gradually increasing over time based on vet rechecks.
And rehab.
Yes, a structured physical rehabilitation program is highly recommended. It starts soon after surgery.
What does that
Things like controlled icing to reduce swelling and pain, gentle passive range of motion exercises to prevent joint stiffness, massage, later controlled strengthening exercises, maybe underwater treadmill therapy, sometimes electrical stimulation for muscles. It really helps speed recovery and improve the final outcome.
Diet seems like it would be important too.
Hugely important. Weight control is key. Every extra pound puts more stress on the joints, including the surgical repair and the other knee.
Right, the contralateral one.
Exactly. Getting the dog to and maintaining a lean body condition is probably one of the most impactful things an owner can do long term.
What about special joint diets?
They might help. Many therapeutic joint diets are formulated with higher levels of omega-3 fatty acids, which have anti-inflammatory properties, and supplements like glucosamine and chondroitin sulfate. The evidence for glucosamine and chondroitin is still debated, but omega-3 seem beneficial. It's worth discussing with the vet.
What are the main things owners need to understand going into this? Client education sounds vital.
It really is. Firstly, understand that even with the best surgery, some degree of arthritis, that DJD is expected and it will progress over the dog's life. Surgery slows it down and improves function, but doesn't eliminate it.
Okay, managing expectations.
Yes. Secondly, that high risk of the other leg going. Owners need to be prepared for that possibility. Estimates are around 37% to 48% risk of contralateral rupture, often within a year or two.
Wow, that's almost a coin flip.
Pretty much. So monitoring the other leg is important. But the good news is, with early surgery and good rehab, most dogs can return to excellent function, even athletic activity for many.
Now, you mentioned different surgeries. Is there one best surgery?
The million-dollar question. Currently, there's no single technique that's universally agreed upon as definitively superior in all dogs in all situations based on long-term outcomes or X-ray changes.
But there are differences.
There are differences in how they work: recovery time, cost, potential complications, and surgeon preference or experience. Some recent studies using force plates, which measure how much weight the dog puts on the leg, suggest dogs might return to more normal weight bearing slightly faster after osteotomy procedures like TPLO compared to, say, an extracapsular repair.
Okay, and the meniscus, if it's torn.
If the meniscus is torn, the damaged part is usually removed. That's a partial meniscectomy. This definitely relieves the pain caused by the torn piece flapping around.
But downsides?
Potentially, yes. Removing part of the meniscus, even the damaged part, can alter joint mechanics slightly and might contribute to faster arthritis progression long term compared to having an intact meniscus.
Yeah.
But leaving a torn piece in there is usually more detrimental short term.
Right. Okay, let's break down the main types of surgery. You mentioned the 3 categories.
Broadly, yes. Extra-articular, meaning outside the joint capsule. Intra-articular, inside the joint. and osteotomy procedures, which involve cutting and reshaping bone.
Let's start outside. Extra-articular, what's the idea there?
The most common one is often called a lateral suture or extracapsular repair. The surgeon places a strong suture material, like heavy nylon or a specialized braided line, around the outside of the joint.
Mimicking the ligament.
Kind of.
Yeah.
It runs from near the femur's attachment point to near the tibia's attachment point, essentially trying to hold the tibia from sliding forward. The idea is that this provides initial stability while the body forms strong fibrous scar tissue around the joint, which hopefully provides long-term stability.
Where does the suture go exactly?
Typically anchored around a small bone behind the femur called the fibula, and then passed through a tunnel drilled in the front part of the tibia, the tibial tuberosity. Placement is key to mimicking the ligament's function.
Any other extra-articular types?
There's also a technique called fibular head transposition. It involves moving the attachment of the lateral collateral ligament slightly by repositioning the top of the fibula bone. This can help tighten structures on the outside and limit tibial rotation and forward slip. Less common now, maybe.
Okay, moving inside the joint now. Intra-articular methods.
These aim to actually replace the torn CRCL with a graft placed inside the joint, following the path of the original ligament.
What kind of graft?
Various options have been tried. Autografts use the dog's own tissue, like a strip of the patellar tendon or fascia lata from the thigh. Allografts use tissue from a canine donor. Xenografts from other species or synthetic materials.
How successful are these?
They've had mixed success historically. Graft stretching or failure can be issues. They are perhaps less commonly performed now than the other two categories, especially the osteotomies. Often, with these, the surgeon might also widen the notch in the femur.
The intercondylar notchplasty.
Right, to make more room for the graft and prevent it from rubbing and getting damaged.
Okay, finally, the osteotomies. Cutting bone sounds major.
It is more invasive in that sense, yes. But the goal is different. Instead of trying to replace or mimic the ligament, these procedures change the geometry of the tibia so that the forces acting on the knee during weight bearing no longer cause the tibia to thrust forward. They neutralize the cranial tibial thrust.
How? Let's start with the cranial tibial closing wedge osteotomy, or CWO.
Okay, with CWO, the surgeon removes a wedge-shaped piece of bone from the front part of the upper tibia. When the two cut edges are brought together and fixed with a bone plate and screws, it rotates the top surface, the tibial plateau, downwards, making it flatter relative to the long axis of the tibia.
Leveling the slope.
Exactly, leveling that tibial plateau angle, or TPA. This stops the femur from wanting to slide down the slope when the dog bears weight. A potential downside is it can slightly shorten the tibia.
Then the TPLO, tibial plateau leveling osteotomy. Sounds similar.
Similar goal, different technique.
Yeah.
With TPLO, the surgeon makes a curved cut, a radial osteotomy in the top of the tibia. Then they rotate that top segment backwards until the plateau is almost level, usually aiming for an angle around 5 degrees.
And fix it with a plate.
Yes, a special contoured TPLO plate, and screws hold it in the new position while the bone heals. TPLO is very popular and effective. It can also sometimes be used to simultaneously correct other leg deformities.
Okay. And the last one, TTA. Tibial tuberosity advancement.
TTA works differently again. It doesn't primarily focus on leveling the plateau. Instead, it changes the angle of the patellar tendon.
How?
The surgeon cuts the tibial tuberosity, that bony crest on the front where the patellar tendon attaches, and moves it forward. It's held in this advanced position by a special spacer cage or wedge, and usually a plate.
What does moving it forward do?
By advancing the tuberosity, it makes the patellar tendon more perpendicular to the tibial plateau slope during weight bearing. This effectively counteracts the cranial tibial thrust forces, stabilizing the knee. Sometimes bone graft is packed into the gap to encourage healing.
Can it fix other problems too?
Yes, TTA can sometimes be combined with moving the tuberosity slightly sideways, medial to lateral transposition, to correct a mild medial patellar luxation at the same time.
Wow, okay, lots of options there.
Right.
What about medications used around the time of surgery or for management?
Pain management is critical. Non-steroidal, anti-inflammatory drugs, NSAIDs, are the mainstay. Like meloxicam, carprofen, firocoxib, grapiprant, there are several options vets use. They reduce both pain and inflammation. The vet chooses the best one and dose for the individual dog.
Important precautions with NSAIDs.
Definitely. Never give them concurrently with steroids, like prednisone, as the risk of gastrointestinal ulceration is very high.
Okay.
And while generally safe, NSAIDs can potentially cause GI upset or, more rarely, affect liver or kidney function, so they aren't suitable for all dogs, and monitoring might be needed. Always use as prescribed by the vet.
Any alternatives or additions?
We mentioned the joint supplements like glucosamine and chondroitin sulfate. Also, polysulfated glycosaminic glycans, PSJs, like Adequin, are injectable chondroprotectives that some vets use, thought to help cartilage health. The evidence is variable, but they're often used as part of a multimodal approach. Other pain meds like gabapentin or tramadol might be used short-term too, especially right after surgery.
And follow-up care after surgery, how long does recovery take?
As we said, rehab is key and takes time. Expect 8-12 weeks, sometimes 4 months or more, of restricted activity and structured rehabilitation exercises for most techniques before a gradual return to more normal activity. Regular vet checkups and possibly follow-up x-rays are needed to monitor healing.
Can we prevent CRCL disease?
Not entirely, especially with the genetic predispositions. But avoiding breeding dogs with known conformational issues like severe hip dysplasia, patellar luxation, or those with a family history of CRCL disease could help reduce incidence over generations.
And weight.
And definitely weight management. Keeping dogs lean throughout their life is probably the single most effective preventative measure an owner can take to reduce stress on all their joints.
What are the potential complications owners should know about after surgery?
Like any surgery, complications can happen, though thankfully major ones are relatively uncommon with experienced surgeons. Things like infection at the surgical site or around the implant. Subsequent meniscal injury. Sometimes the meniscus tears later, even after the knee is stabilized. Issues specifically related to the implants, like loosening or breakage, though rare with modern implants. Problems with the bone healing, especially with osteotomies, like delayed union or non-union. Tibial tuberosity fracture is a known risk, particularly with TTA. Patellar luxation could develop or worsen. And sometimes a subtle rotational instability called pivot shift can remain, but it usually doesn't cause clinical problems.
But overall, the outlook is good.
Yes, very good for most dogs. With appropriate surgery and post-op care, the success rate is generally reported as over 85% for return to good or excellent function.
That's encouraging.
It is. Most dogs can get back to enjoying a good quality of life, being active and comfortable.
So let's try and wrap this up. It's clear CRCL disease is, well, it's complex, isn't it?
Definitely. Lots of factors involved. Causes, risks, treatment choices.
And understanding those nuances as you've laid out seems really key for owners and vets making the best decisions for a particular dog.
Absolutely. And remembering those key takeaways is important for you as an owner.
Like the arthritis.
Yeah, that DJD is pretty much inevitable to some degree, even with surgery. It's about managing it long term. And that huge risk, nearly 50-50 of the other knee being affected later on.
That really drives home the need for ongoing monitoring and care, doesn't it? And keeping the weight down.
Precisely. Those are probably the most critical messages for long-term management.
Which leads us to our final thought for you listening today. We've seen amazing progress in surgical techniques, PPLO, TTA, better rehab.
Huge strides, really.
So considering all that, what might the future hold? Are there exciting possibilities on the horizon for preventing CRCL disease more effectively or managing its long-term impacts even better for our dogs?
It's a great question. Maybe better genetic screening, earlier interventions, new biologics definitely gives us something to think about and hope for.
Indeed it does. Well, thank you for joining us for this deep dive.